Dr. Popov is an assistant professor in the Department of Learning Health Sciences with a courtesy appointment at School of Information. He's also the director of Learning Sciences and Technology for the Clinical Simulation Center for the University of Michigan Medical School. His research primarily focuses on understanding how team function can be optimized to lead a better learning gains, performance, and healthcare outcomes. His current projects, of course, he will present on and talk about today. So, Dr. Popov, we welcome you, and I will hand the mic over to you.
Thank you. Thanks, Jamie. Always a pleasure. Let me see, and I apologize for those who attended the ISQE conference in Denmark. So that would be a little bit of a repeat, but for those who didn't make to my presentation, that would be a brand new content. So let me see. And yeah, you should be able to see the whole, All right, so as you can see on the slide, the title of my presentation is Leveraging Epistemic Network Analysis to Discern the Development of Shared Understanding Between Physicians and Nurses. And that was a true interprofessional collaboration with the School of Nursing, with the Professor Melissa Manojlovic. So she was the content expert who actually was kind enough to offer to do the secondary data analysis on the data that she collected a few actually years before COVID. Because you understand why is it important, because there was a film crew with a GoPro camera followed physicians and nurses in 2 oncology units in the hospital. And of course, when the COVID happened, of course, that research wouldn't be very complicated to do. And also you can see on the screen our lovely and talented undergraduate students, because, when you do quantified ethnography, you do need the human power to label and annotate data. And that's where the students came in. All right. So the foundational question that led this research, you can see on this screen. What patterns of physicians nurse communication can support, hinder, lead to a shared understanding? So we're looking for those patterns. And why is it important? And why do we need to know? Why is it so important to know about these patterns that hinder, support, or lead shared understanding between physicians and nurses? And the answer to this question is that the poor communication between physician and nurses is one of the leading causes of adverse events. So obviously, the poor communication between these two healthcare professionals can lead to poor patient outcomes, waste of resources, and the medical errors. And of course, when we in this particular setting, we did the study on the 2 oncology units, of course, a lot of immunocompromised people, so that the stakes are even higher. And I will show you a very short clip to kind of to give you an idea of how the data look like. And before I do that, I need to give you some context. So what you're about to see, actually in this very short kind of 7 minutes, you will see all the features that is relevant to the teams in healthcare. It's fascinating example. You will see decision-making, psychological safety, coordination in this very short 6 minutes. So the case here, so what you will see on the screen, you will see a medical student, you will see an attending physician, senior resident, a pharmacist, and a nurse. And there was also a pharmacist, a person who was assisting a pharmacist. But anyway, the case was, for those of you who are not familiar with the C. diff as a contagious disease, it's not, the most serious thing, but usually people tend to develop it after a week taking antibiotics. And it's very contagious. If people, touch the surfaces or interact with a person who is sick with C. diff, it spreads very quickly. And again, you can imagine that it's an oncology units, and again, immunocompromised people, and when the physician and nurses, they go on patient rounds. So you can imagine that it can spread very quickly if you go from one patient to another patient. That's why there is this precaution measures that usually you need to wear a special gear or attire to protect the healthcare team. There is also a sign on the door, and what you're about to see is that in a matter of seconds, how they are deciding to take the sign off and do not wear this attire, although there were inconclusive tests. And you will see how this communication kind of unfolds. All right, let me play it.
Not really too much happened yesterday. We switched to his zosynthesepine because of the concern for drug fevers going on. He hasn't fevered since, so maybe did something. His repeat C. diff, interestingly, is negative. So he has a negative one, and then the PCR was positive. And then the C. diff after that has been negative. And he's like, he has been having intermittent diarrhea, but he had like a whole day where he wasn't passing any stool. So we took off the vanc for now. We'll see how he does. It just seems like we were talking to the IDE fellow curbsided yesterday, and it sounds like the C. diff, like the assay itself, is more sensitive than the PCR, even though the PCR is pretty sensitive. So we'll hold off on that for now, just to peel off one antibiotic and see how he does. Otherwise.
So I will fast forward. Then the pharmacist will take his 2 cents about.
Not really too much happened yesterday. We switched to his.
Cool.
So even this GI PCR.
Yeah, the GI PCR is incredibly sensitive.
Oh, sorry. Somebody just come into the. Here we go.
Not really too much happened yesterday.
Any patient that's colonized, because it detects the gene and not necessarily active disease. So if we tested you, you'd probably be PCR positive with.
So even this GI PCR?
Yeah, the GI PCR is incredibly sensitive. All C. diff PCRs are.
What about the, because I've heard the antigen, if you have it, then the antigen's always, like if you've had it in the past, the antigen shows up, right?
Not necessarily.
Okay.
But so what we'll do is if the antigen's negative, but the toxin is positive, then we confirm with the PCR.
Okay.
Or if there's any discordance between the immunoassays, then we'll confirm with PCR. But if those two are negative, you can be assured that the patient doesn't.
Okay, so on the actual C. diff assay, if the toxin and the antigen are negative, then
if the PCR is positive, it's likely colonization.
Okay.
Yeah.
So I wonder what % of the normal population is colonized.
Yeah.
It's like we walk downtown Ann Arbor and check 100 folks. What % would be?
You guys don't have to put this on then because he has a history of C. diff, but not actual.
So you see, they were taking out this protective gear, but at this point, the senior resident making a decision that they don't have to wear it. Although, they had to spend all this time discussing about different tests. And again, nobody challenges that, they said, okay, we don't have to wear, they're about to enter the patient's room who can have a C. diff.
Oh,
We're gonna take the sign off.
Okay, that's right. Cool.
before we go off.
We should probably take that PCR off that panel though. Kind of.
I'll let her know.
So here will be probably relevant. So they are interacting with the patient, and that's where the communication with the nurse will be happening.
Precautions. We tested infectious disease yesterday.
Oh.
Still having loose stool, and the antigen was present.
The antigen? No.
Or the toxin.
That was only the PCR, but we got a newer test that's been negative.
Right, but the infectious disease yesterday said because he's still having loose stool, he still needs to be on C. diff.
With that positive panel, despite 2 actual negative.
And you can see how attending physician immediately washes his hands while they're still discussing.
C. diff test?
He didn't have 2, he had 1.
There was another one after.
On the 5th he was positive, on the 7th he was negative.
But there's no. So there's 3 C. diff tests. 2 of them are the actual antigen toxin ones, which have incredible sensitivity and specificity. And then the 3rd one is the GI panel.
I just know they called infectious disease yesterday and
clarify
said
with
that he
them.
still needs to be on C. diff. So we can just call.
We'll clarify with them and then make sure
because
confirm.
our infection control is like incredibly strict,
Crazy.
even when things don't make sense.
Yeah.
Which is, it sounds like it doesn't make sense. We still keep them on contact. But I would talk to them because it does.
Yeah,
We'll sort it
I'm
out.
gonna-
Yeah,
Okay.
we'll talk to him directly.
So we'll leave it. We will
leave it for
leave it
now.
on for now. But if there's any changes, we'll let you know.
Okay.
Sounds good.
Yep.
Thanks.
Thank you.
So you guys
Oh, here we go.
should probably wash your hands.
Yeah.
We see, oh, sorry. So here she advised to wash the hands, and just the last one, I will just show the kind of the sigh of the senior resident at the very end.
You said he was having blood in there, though. Apparently not.
No, he's not.
So anyway, to kind of to showcase again how the data look like and what we exactly we focused on, and also you can see kind of the again the importance of this interaction between the physician and nurses. So what we did when we so let me show here. So in total we have 33 videos of this type of interaction. So over 200 minutes. And you know, for those of you very much familiar with ENA analysis, so basically that was our workflow. We transcribed the data, we segmented areas of interest, and then we annotated the video. And I'm very happy that actually Sarah is joining us from the car, because a few months ago I reached out when I was shopping for a coding scheme. I reached out to Sarah and said, like, you know, do you have any suggestions? So you have any experience with this verbal response modes coding scheme? So that was cool. That was exactly the moment when we decided, okay, we probably when it comes to annotating these interactions, we can adapt this coding scheme. So verbal response modes, it's a coding scheme developed in the 90s by Stiles. It has this 8 communication acts. Most of them are self-explanatory, and I will show you kind of the example from the data set and exactly the description of all 8 categories. But what's interesting about this coding scheme that you can, each one of them has a function of the literal function and the implied one. So there is this grammatically as communication act could be a question, but the implied meaning of it could be a request. For example, if I ask my 6-year-old son, could you please be kind to your younger brother? Obviously, it's not a question. It's an advisement. So you see, I'm trying to guide his behavior. I'm not questioning, you know, it's not, I'm not asking anything. But anyway, so here you can see kind of examples and definitions of the VRM, verbal response modes coding scheme. And for the purposes of this study, we coded for the intention. So we did not code for the grammatical meaning of that communication act. And I want to draw your attention to these 2 categories, edification and disclosure. They were the most prominent in this data set. Again, edification, somebody states subjective information. Mostly it's a factual information. Somebody has a fever or some kind of diagnosis, and disclosure, it's more your perception of that information. It's like, you know, you would say my take on this, and then you express your perception of it. And we used Elan software for segmentation and annotation purposes. Again, if you are searching for software for this type of purposes, I recommend you. It's open source program that allows you to load the video and then, of course, do your transcription and annotation and segmentation. And here's an example of the interaction, and you will see how the edification moved, then acknowledgement and disclosure. So the results, so here as you can see the descriptive statistics. And when we share this work with nurses and physicians, one of the questions you would say like, oh, but the conversation is very dynamic. And then we say, yes. So when you look at this data, of course, it gives you some indication, of course, where people spending most of their time, but where the ENA shines, it's exactly trying to account for this the dynamic nature of the interaction. So what you see on the screen, so this is a general model when we put all our data set in, model the whole lines in our data set. And the most common connections were between the disclosure and edification, question, and acknowledgement. Those four were the most prominent in terms of the frequency, and again, the co-occurrence between them, which makes sense. Because again, nurses basically mostly engaging in the edification in the patient rounds when they share some information in the morning, and physicians share their perception of that information with some acknowledgement and follow-up questioning. And there were very modest connections of confirmation and interpretation, which was kind of surprising for us. But then what was cool about this study, that we had the idea of, to take it a step further and able to do a subgroup analysis based on Melissa's prior work, when she had a group of experts and they also studied this data set. They had their own criteria for shared understanding. So they were able to create two groups: the physician and nurses who reached shared understanding, and those dyads that they did not reach shared understanding. And they used these four markers of shared understanding: engagement, clarification, confirmation, and resolution. So they already have kind of idea to classify them. So we adopted this classification, and then we're like, okay, if we split this data set and based on this criteria of, the dyads who reached shared understanding and the dyads who did not, and then we said, okay, let's look at those patterns, ENA patterns of communication in those two classes of physician and nurses. So what you see on the screen, this comparison ENA model, and in the blue color, you see that the dyads who did reach shared understanding, and in red, who did not. Again, both of them actually had, again, the same similar pattern of the structure between edification and disclosure, and edification and question, but less so for the dyads who did not reach shared understanding. And now I will show you kind of one by one, because it's harder to disentangle when it's all the two networks presented together. So again, you can see even the nodes, obviously the size of them also shows you how frequent those VRM codes, but also one of the hypotheses for why these physician and nurses who did reach shared understanding, what was so kind of what basically led to this, that they did reach shared understanding based on the VRM codes. And the hypothesis is maybe they were more efficient in their moves. Maybe they just spent time on this edification, question, and disclosure, and they didn't spend their energy or time on other types of moves. Let's say there was not much confirmation or acknowledgement. So one of the hypotheses, they were more efficient in this kind of type of exchanges, versus the dyads who were classified as did not reach shared understanding. You can see they're spending more of their interaction on confirming, acknowledging, and a little bit on advisement. But again, very few on reflection and interpretation. And the main takeaways here, again, that we've seen in both types of physician and nurse dyads, those who reached shared understanding and those who did not, that edification and disclosure were the most prominent type of interaction. Then the reflection and interpretation were actually the least used VRM codes. And this might be one possible area for intervention development. And again, the strengths of this, of the QE and ENA that it points out the exact communication pattern that should be improved upon, reinforced, or avoided at best. Because again, when in 2019, when Melissa and her team look at this data, they were struggling to open this black box. But here we can see exact patterns and we can kind of zoom in on those rather than have kind of a global perspective. Okay, did they reach shared understanding or they did not? So let me stop here and open the floor for questions, clarifications. Thank you.
Wonderful presentation, Vitaly. Thank you for your great insight in this project. We'll open the floor to questions. Does anyone have questions? You can either post them in the chat or raise your hand and unmute yourself.
Hi, Vitaly. Thank you for sharing your great
Hi.
work. So I'm wondering, are you interested in, looking at other modalities in the future work? Maybe I just missed that you already mentioned it in your presentation. Like as you showed the video, there's a reach dynamic between their physical location and, moving actions. So are you interested in like expanding the scope of data to other modalities?
Sure. The nonverbal communication is absolutely critical. That's why when showed you in that video clip at the end, when the senior resident sighed, there was so much in that, seconds, but there was so much meaning in that. You're right, that if we could expand and do another analysis and add this kind of nonverbal behavior, I'm curious how would this kind of the results will change. 100%. This would be huge if we can include. Of course, it's labor intensive to annotate, but the efforts might pay off.
I just want to build on that, and yeah, I think a follow-up study looking at other modalities is important. I never actually realized when I had seen you present this the first time in Copenhagen, but I'm now realizing that there is a lot of information in that video clip that I didn't see before. And one of the things is relational context. And there seems to be sort of a power dynamic. It's most apparent when is it the chief resident? When she's interacting with particularly the nurse. So cutting her off and talking with sort of a frustrated tone. But then it's funny because when the nurse is sort of making the argument, she's actually corroborated by the other three providers who coincidentally in this scenario are all male. And the chief resident, she just sort of bends a knee to the argument that the nurse is making. So it kind of makes me wonder if those other three providers were not present, in this conversation, would the outcome have been the same to either keep the status of the patient's room as positive or negative? And I'm not sure whether or not gender would play a role in that. I'm sure, or I should say sex, or maybe both. But yeah, I just wanted to build on that and all. Good point. Does anyone else have other questions?
I have a comment or some things that I kind of wanted to highlight. That's good too. But one of the things I think really struck me about this work, both in Copenhagen, and I think it's reinforced now. I agree with what people are saying about the potential richness of looking at different modalities. The Psy was paying attention to body language. There's different levels of frustration or other things that you could get at with tone if you wanted to look at that, because that's some interesting dynamics. And I think I agree with folks that that's worth exploring. But I also think I wanted to like kind of zoom in on some of the ways that Vitaly framed this, because I thought it was really interesting to me. One is like the in two cases where you had like kind of the code and count of like, we look at these different moves and we see some things are happening more than others, but we're not getting as much of an understanding of what's really going on, and that ENA is allowing us to see that. And also the opening of the black box of like the shared understanding. I think that's a pretty common thing that happens in a lot of different types of research, where if you bring in a QE approach or you're bringing in ENA, you're able to get fidelity on something that you didn't have before. So you're getting greater, maybe greater analytic leverage. And I thought that that was kind of cool that you brought that into the narrative of the research. So that was really cool. I also like how you led with the qualitative example first before you even talked about your methods. In terms of like how you're presenting it and doing storytelling, that's very powerful. And I know I've heard other people kind of advocate for that within QE practice, but I think this is a great example of that. And I'm glad that we have this. We're going to have a recording of it because it's something we can point to folks. There's two other things too I'm pretty excited about. So I'll try to be short. The other one was you talked about also these subgroup analyses, which I think is really important for fairness. And you have a concrete example of that. So that's a really important thing too, in terms of being able to use these models to kind of hit different levels. I've seen different areas of critique, even in meta-analyses or other things where people use kind of aggregate models of things. So think about like effect size in a meta-analysis. If you use an average effect size, but there's heterogeneity, like you might want to unpack that, and you're demonstrating one way to potentially do that. Obviously not at a meta-analysis, but within one analysis. But we can see the importance of that if there's differences for subgroups, which is really crucial, I think, for fairness. And the last thing I want to point out is that is a great example of a really robust study, and I think incorporated with a bunch of other things, that's in the health and healthcare space, which I think is the more we continue to have strong examples from that, that's really good for the QE. Like if we zoom out a little bit and just think about QE as a field for a second, that's really good. And obviously you, like Sarah was here earlier, you both have backgrounds in like learning sciences and stuff, but also are obviously now couched centrally in healthcare. But this is another example of how perspectives can inform each other, because you also talked about potential interventions for practice. So I think about those are just some things that I think are really strong in this and are worth reflecting on and unpacking outside of the specific result in turn, like as far as we're thinking from a methodological perspective. I just think those are really strong. And I think for me, as someone who tries developing folks in this area and their methodological skills, like this is a solid example of those things. So I just wanted to kind of mention those things as things I really appreciate.
Oh, thanks, Brandon. Yeah, and if I can respond briefly, no, you're right. Especially when I came into this project, the nurses and physicians, with 20-25 years of experience, by looking at these 33 videos, they could tell, who reached shared understanding and who did not, with all the years of experience. But it's like those glasses that are blurry, and the ENA allows us to calibrate the focus, because they didn't know what exactly is wrong. They could tell that, and using all their human emotional intelligence, what Sanal was said, like nonverbal, they use everything of that kind of to make sense of it. But here only, stripping the nonverbal stuff and just using the textual information, we're still able to, and of course, that's how the human communicate. Of course, they use words, especially in the healthcare, when you have to be able to articulate clearly. You can't just, say, okay, I don't know, but you have to really communicate that and state your point. So you're right. So that allows them to see those improvement targets. Because again, they want to, train and change this.
I think one of the interesting things too, as well, is environment. And I think this is where actually using video recorded data can be a useful data tool over transcript data, because there was a lot of visuals there that we wouldn't have been able to see if we had just looked at transcript data or speech text. For instance, the motion of grabbing the gowns to go in the room, I assume that they are, I have a pretty good understanding of how clinicians operate in a clinical space. Most of them are running pretty much an autopilot and doing what they've been trained to do and trying to follow the SOPs as best they can, because healthcare, as you know, is incredibly standardized. And so they seen the sign on the door. They were having a conversation about, whether or not this patient's status should be positive or negative, or they should consider it based on the sensitivity and specificity of the tests. But they seen the sign in the door, which trumps everything that they just talked about, and they're going to put a gown on because there's a sign on the door. So there's a certain level of sort of automated thinking or second level thinking, I think, that is inherent in that scenario. Yeah, it's really interesting.
And again, you see, in hindsight, it was like, why would you kind of, err on the side of caution? But they, and it's interesting, like at that moment, that one person makes a decision and they follow. Yeah, no, that's kind of fascinating. Yeah, anyway, and again, even you see, even before they entered the room, they could have found the nurse who's responsible for the patient, because she comes in even later. Maybe she was, seeing other patients or something. But yeah, and again, it's easy for us kind of, again, in retrospectively look at this. But when you are in the heat of the moment, when you're right there, they, made this executive decision, and then of course she said, you probably should, wash your hands. Yeah. Yeah, no, good point.
Can I ask another question, Vitaly? I'm wondering, so obviously, some of us had the benefit to see you work in Copenhagen, and obviously you're doing this as part of the webinar series. I'm wondering to what extent you've been able to share these same results in kind of healthcare research spaces that maybe are like not really that QE might be newer to, or they don't necessarily focus on that, and what the response has been like. I mean, you one colleague who was excited that, like, she'd done this stuff around the shared understanding, but then she could get further. But are you finding that this is good uptake, or people are having a hard time following the network analysis part, or what? How is it? If you have shared it, how has it been received?
Sure, I did share this work on a couple of venues. The room full of physicians and nurses. The one question when you present an ENA model, the question is about the direction. So even when this edification and disclosure, so the sequence, what follows what? Am I first presenting you with information, then I'm my perception on that information, and then follow-up question, or start with a question? So ENA, and I know folks are working on the directed ENA, but that was definitely came up in all the time when I presented this work, like how exactly, what's the sequence, what's the chronological order? So that will be number one. Of course, people sometimes struggle with this, with hyperdimensional space. I mean, like, what's the rationale behind the positioning of the codes on the axis?
I was. Oh,
sorry. Go ahead. Go. No, that's it.
Sorry, Vitaly. First, thank you for sharing your work. Before you mentioned the order, I was about to ask my question. Was like I was wondering, like I was asking you about like why you're doing this ENA analysis. Is there anything you want to do but ENA couldn't? And then you mentioned the ordered aspects of the data, which so I am working on ordered network analysis. And then it's very similar to ENA, but basically it can show you the direction of the connections. So in your case, I think it would be very interesting to compare like networks of people in different roles, and then because they might have similar connection strength between certain codes, but the direction can look very different. We see some like interesting phenomena like that in other contexts, like when I think in our like demo, we have like education simulation data. Students from different performing groups, they make similar connections between same pairs of codes, but when we look at direction, it's very different. And then we look at their qualitative example, those utterances, and then figure out, oh, one is having question to a code and the other is having answer to a code. So I think it would be very interesting to try your data on ONA.
Sure. So reach out to me and we can rerun the analysis and look at the directions, because that you see, taking it a step further, again, you see with UID and synalcity, if you bring these two additional layers that can give even more power, Like, for example, when the nurse was challenged, and she was like, I don't know, you kind of deciding. So that would be maybe a point when you educating and training people, you're like, okay, that's a point when there is this nonverbal reaction, and that would be a point maybe to ask an additional question or confirmation, any type of that will try to, you see, at this point, kind of, she said, like, it's up to you. But I think it could have been more productive in some sense. You see what I'm saying? Kind of, again, getting your sequence, and then I know the number, the sequence in the short term, it's easier to rerun and see the directions. The nonverbal stuff would require another army of undergraduate students to annotate. Yeah.
We have another question in the chat from Danish, who says, thank you for the presentation. It was very informative. I'm wondering how you would interpret the 4 ENA quadrants with respect to VRM. And a follow-up to that would be, does the network structure change if you include more units or episodes into ENA? And then I also want to just acknowledge, Hanal, you had a question after that as well.
Let me see. So I'm reading the question. The second question is absolutely yes. Of course, if we include more units in episode, of course, then it will begin to change. I don't see that much movement on this edification and disclosure. It's one of the most prominent links, and that's the nature of their interaction. Again, on this patient rounds. So I don't anticipate, even if we remove or add 100 more video segments. So I think that will just reinforce that connection. But on the first question, I'm trying to understand 4 ENA quadrants with respect to VRM. I'm a bit struggling with that part.
Well, maybe Danish or Danish could follow if I were to take a guess at it, it might be, how would you interpret being left or right or up or down, and what would that mean with respect to the VRM? But I don't know for sure if that was what the question was.
Yes. Hi. Yeah, exactly. As Brendan had shared, similar to those lines, how will one interpret, say, for example, if confirmation or acknowledgement is in the right end of the axis? So will it mean that the interactions are of one style, or how does it happen for this VRM as the choice of framework?
For the VRM, let me show here. I mean, obviously, the coding scheme is kind of generic enough. That's why it was applied in all kind of in many fields: aviation, psychology, counseling, consumer studies. So you see, it's kind of generic enough to kind of to get your hooks on the human communication, but it's there is also some logic to that. Obviously, acknowledgement probably will be come in when there is some kind of a question. So you wouldn't lead a conversation with acknowledgement or reflection unless you have some kind of philosophical communication. So there is some structure to that. And again, of course, it will depend on the context. Like in our setting, the communication between physician and nurses, it made sense. The disclosure, edification, confirmation, and question. And again, but again, it might be the case when nurses are reflecting more. There is more confirmation. You see, it's not really prominent here, but I'm sure if we took this coding scheme and apply, let's say, in operating room, I'm curious how would this look like. We all probably know about the importance of the closed loop communication. There's a call out statement and confirmation, and so I'm sure that would we'll see a different. For example, I'm sure that confirmation and let me see.
You had said that this was on oncology?
Yes.
Okay. So I was also thinking ER. I wonder what because I mean, it was so busy and bustling. Yeah.
Right. Maybe sometimes there is no room for this kind of reflection, or if you, let's say, if you see some kind of if we go to diabetes counseling, like there is some kind of shared decision making, maybe we'll see definitely more of this reflection and questioning and interpretation, because
yeah, well, I mean, yeah, diabetes clinical environments are really heavy in terms of self-management support theory and things like that. But yeah, hopefully that answers your question.
Could I actually just if Vitaly, if you pull the network back up, I might take a stab at kind of, so the one way I would look at this is, if let's just take a couple of the extreme plotted points. So the one that's right up by acknowledgement, the way that I would interpret that is that the person that's being represented by that dot is many more connections, most likely to acknowledgement and question and acknowledgement disclosure, versus the dots that are way down at the lower right hand side. They're making more connections to confirmation to some, and then the folks that are in blue that are pulled more to the left or maybe up or down are spending more time connections between edification and question and disclosure. And as we saw on the previous network, it's not that the folks don't do that, they're just not doing it as much. And so that's how I would kind of interpret that piece, is what those where points are, those the plotted points are within the space, is reflective of the pattern of connections that are happening. So I don't know if that also gets at what you were wondering about.
So recognizing the time, and we have 2 other questions in the queue, I'll hand the mic over to Hanal.
Yeah, so my question is about more like general questions. So I recall that you share these results to nurses and who are actually in this data set. And do you plan to use this ENA as a like interpretable outputs? Like, here's the thing that you've here's the thing that you had discussions in this particular context, or it's just for understanding what is going on as a researcher perspective? Like, is it the output that will be shared to the end users, or is it the analytic output for researchers to understand the situations and learning phenomena? Yeah.
Yeah, but definitely both. Actually, Melissa Manuelovich from the School of Nursing, so she is using this interesting technology. It's called video reflexive ethnography. When she brings this, the actor, the stakeholders who were filmed or video recorded, when I'm use film, my department should always correct me, like, are you like in the 80s? There is no more film, anyway, so you and then you show some of these segments. And then you ask people, okay, what was going through your mind? Why do you think, what's kind of the reason for this communication breakdown? And then people begin to reflect, and it's more kind of a more formative feedback. And I'm thinking about, what if you can pull the framework, not in addition to the video segments, but you pull their customized individual ENA network for the dyad. And of course, the question is, would it help? Because we all know that it does require some interpretation dance when you use the networks. But I do see the benefits when you can actually go exactly to, because if you click on this link, it will bring you exactly to the text. And of course, in addition to the video, I think there is some power to that. And again, as to my earlier point, when you just show with the video clip, it's so much kind of interpretation and guidance, whereas here you can be more targeted and focused. And again, see, let's say if you follow this diet for 1 month, you can see kind of how this progression of this over time. Yeah, I would say both, as a research tool and as a kind of the human in the loop.
Yeah. Okay. Yeah, that's what I understood too. Yeah. Thank you.
Sanika in the chat has a question. says, thanks for an insightful presentation. Can you please explain a bit more about how you defined epistemic frames and stanzas for this study?
Sure. So it was actually great question. So the conversation between the physician and nurses, usually they talk in very short sentences, because very quick. It's not like long-winded conversation. So the stanza actually was set to 12. So about 12 lines in that window. Because when we make it short, it didn't make sense, because a lot was like, okay, and so there was very quick and short exchanges. And let me see, and what else was the question besides the stanzas?
Epistemic frame.
Can I ask more?
Sure.
Yeah. So the selecting of stanzas are based on basically on those give a meaningful, overall meaningful something, right? The defining of stanza should be like, there should be come out something like meaningful observation or meaningful understanding should be there while defining the stanzas, if I'm not wrong.
I hope you're not, but it's like it's a Goldilocks, the most optimal that suited to the nature of the data set. It shouldn't be too small or too large. I'm sure Brendan probably will have.
Yeah, I mean, I can chime in. So there's a paper that explains kind of one method of establishing what your window size should be, and also demonstrates that a lot of ENA models are often robust to changes in window size. But I think kind of the important thing about what Holly was saying is, based on their team's qualitative understanding of the discourse, they needed I'll say wider, because a lot of times people will say 5 or 7, or the default in the tool is 4, but because there's these kind of quick interactions to capture the patterns of that they were interested in qualitatively, they opened that up to 12. So basically they're making kind of a qualitative claim about, this is what I think is a meaningful context, temporal context, or number of lines, the common ground in the conversation, based on the nature of these teams and how they're interacting. And I might just toss in really quickly too, in terms of the epistemic frame, what Vitaly said before about scheme from Sarah was, that's one way that people are focusing on important elements of these types of teams in healthcare's discourse. So in that case, this would be one way of taking a slice epistemic frame of these healthcare teams based on that coding scheme. Sorry, that's just my thing.
You're right. If we did exactly the same study, let's say somewhere in Denmark, we could have observed different patterns because of different culture and the nature of exchanges versus in the Midwest United States.
Okay, thank you so much.
Does anyone else have any other questions? We've got about 5 minutes on the hour. It's interesting. I'm working on a review right now on self-management support and trying to compare health systems and healthcare providers' perspectives on care around self-management support specifically. And it's funny because, in the European and Scandinavian countries, there is a strong emphasis on, diagnoses, diagnostic tests, medications, and how can we adequately treat this person. In North America, there's a strong emphasis on shared understanding, multidisciplinary care, and how does my medical recommendations compare to, say, what the pharmacist is doing and other things. So I wonder, if cultural context, I think, would play into that as well, because this oncology hospital setting is in the United States. Is that correct? Yeah.
Yep. Yeah. No, You're right. That's where indeed the epistemic frames matter. How you approach this, and what kind of patterns you see in your data set, and what are you coding for. I'm sure, actually, in the course that I'm teaching, when I shared this data set with the students, and I asked them, if you could add just one more code to this framework, what could it be, and why would you add this an additional code? And of course, students had different. I think they also kind of took it more to the nonverbal stuff that wasn't kind of present in the speech text, like confidence, and I'm forgetting something else. But it was definitely, we were kind of applying our epistemic frame as researchers by looking at this data set. And you're right, it might be something that is in a blind spot here, and again, the patterns that prevalent in oncology units could have been different on, let's say, in ICU floor. Yeah. Great questions.
Well, thank you for your time, Vitaly, and for everybody who joined us on this first QE webinar session for 2023. Keep an eye on your inbox. Probably in the last week of May, we will be hosting Mariah Knowles, who you all know, who's going to be talking and giving an update on what she's been working on recently. And if you have suggestions for speakers that you would like to see, or if you're interested in presenting yourself, you can contact either myself or Brendan, preferably Brendan, because then so thanks for your time, everyone.